sir. Our next talk is on recognition and management of rhexis extension by none other than Dr. Ramamurthy. Sir needs no introduction. He is the chairman of Eye Foundation Group of Hospitals, and he is an renowned phaco and refractive surgeon, and with vast experience. Over to you, sir.
Thank you so much, Dr. Sandhya, and thanks KSOS for this wonderful opportunity. This is a topic given to me. Let me try to illustrate the points I want to make with the help of some practical videos. This is an old video of mine, and one of the factors that you need to understand is that the reason rhexis extension occurs is because whenever intralenticular pressure exceeds the intracameral pressure and the anterior capsule bulges forward. This is an intumescent cataract. I'm observing all the usual steps. I made a small neck, went inside, used cohesive viscoelastic, basically removing cortical elements. Whenever it's flocculent, you may have to do it in more than one occasion. And then initially started off with the capsular rhexis needle, then using the utrata forceps because it gives. But watch here right now, there is escape of viscoelastic, the chamber is shallowing, but I got tired of doing this rhexis, and that's when it gives way. Ideally, what I should have done is to stop right there, refill with viscoelastic, and then gone ahead. Manage the case and manage to put in the intraocular lens, but obviously a compromise solution. So the point I want to drive home to the youngsters is you might have to, in these kind of cases, even 3-4 times you might have to refill. And once the you get a rhexis in this particular situation, the case is almost 80% over. One of the other reasons for a rhexis extension happening is a fibrotic element like this. And you can see me trying to do this. If I use a utrata forceps and just try to pull this along, this is going to rip through to the periphery. So that is something you should not do. And essentially, I'm using a micro rhexis forceps. There's a certain amount of distortion of the wound because of the direction. And I create a nick over there so that you can still see that the capsular rhexis, at the edge of it, you can see that fibrotic patch. If only I tried to drag this over, then it would have ended up with a rhexis tear and anterior rhexis tear, which could obviously have a propensity to extend across the equator. Look at this situation, little more serious than what we saw in the earlier case. It's an extensive fibrotic patch over here. Fortunately, here again, it's close to the main incision, which is temporarily placed. Essentially, I've done a laser LRCS in this case. That's why you see the capsular rhexis margin over here. But exactly in this region, we have a fibrotic patch. If you try to stretch this too much, or even use a utrata forceps and try to drag this out, then invariably there will be extension to the periphery. In these situations, sometimes depending on the situation, you might even have to make another incision, use micro rhexis forceps, go along to that area, and then cut the area of the fibrosis, and then subsequently proceed with the rest of the scenario. And as you can see over here, that fibrotic patch is still there, but centrally it's a clear capsular bag that we have, which is ready to receive the intraocular lens. Even when you're using a LRCS, please concentrate in this area. You should not automatically assume that this is a very simple walk in the park case, but you can see over here that there is an area of discontinuity over here. And I did identify that, and you would see the way it's not a simple down-up technique that I practice, but essentially I would make sure that I swing the rhexis in such a direction that I create the rhexis in this area. Basically, this is a discontinuous area, and if I had just pulled on the rhexis, then it could have just ripped apart. Once the nucleus is removed, you can see this area where you can see that small bulge over there, which has been artificially created with the utrata forceps because the laser did not do it. And you see a small nick like this. This can happen either because of the phaco tip or because of while polishing. And in these situations, if you go ahead and introduce the intraocular lens, again this can extend posteriorly. So what we do, you can use a utrata forceps or a micro rhexis forceps. I use a aspiration cannula itself to go ahead and round it off. It's extremely important you do that. Otherwise, if you just try to introduce an intraocular lens with that small nick over there, invariably it will extend to the equator and maybe beyond. Look at this interesting situation. I have most of the rhexis is almost done, but right here, whenever it is pointing towards the equator, that's a dangerous situation. You know you can be in trouble, and basically this is a more recent case of mine. And essentially, what I did is to go through the side port with the micro rhexis forceps. I round it off. I thought that the case will get over quite comfortably, but still, even though we have a rounded rhexis here, there is an area of weakness. And when I did a limited hydro dissection, immediately I could see that this extended. And you can see this going all the way to the equator. Fortunately, not extended beyond. When you have to deal with the phacoemulsification, a situation like this, use low IOP, moderate parameters, and go ahead and with the whatever technique of your choice. In these situations, even a stop and chop is good. But you can see the more tentative way I am doing it, in the sense that, and the chopping also, to the extent possible, it's not along the line of the rhexis runoff. And once I've made my initial chop, I bring the nucleus fragments out into the anterior chamber and do a horizontal chop, so that there's no stress on the capsular bag. And now it's a dispersive viscoelastic that's going in to protect the cornea. Then some amount of normal HPMC, because the dispersive viscoelastic itself is thermogenic, and all the nucleus evacuation is done in the anterior chamber outside the capsular bag, though as posteriorly as possible, so that the deleterious effect on the endothelium is also not there. And obviously you would refill but the amount of phaco power used was quite minimal, and the phaco probe assay stays in the center without moving. You can see the large rhexis runoff that I've had, but obviously it's doable to go ahead and do a phacoemulsification. Another situation where I have a rhexis runoff, most often it occurs when you think the rhexis is over and you are slightly relaxed, and often some of the viscoelastics has leaked out, and you can see here again I have a rhexis runoff. And as you can see here, it's a very soft cataract, not amenable to chopping. So essentially what I do is to go ahead and create a central crater. Again, the parameters I use are significantly less than what I would normally use, but then hardly any phaco power is needed. And subsequently, I rotate the nucleus by 90 degrees, and the separation I do with two Sinskey hooks, and not creating any stress on the capsular bag in these areas, and then subsequently removing the nucleus. Again, it is in the anterior chamber phacoemulsification that we essentially do, after which the intraocular lens is introduced. This is another situation. I essentially want you to look at this brand little maneuver, and I go ahead and inflate with the viscoelastic, start with the rhexis, and everything seems to be going according to plan. But there is one stage over here when there seems to be a tendency for the rhexis to run off to the periphery. So essentially, just keep watching this. As you can see, I am doing it more carefully, more consciously than what normally we would do. But this is the point. I am evacuating a little bit of cortical matter from the bag, so as to lessen the intralenticular pressure. But can I take a minute more? As we see here, this is tending to direct in this direction. This is a dangerous situation. The brand little maneuver is nothing but the tendency would be to push in this direction, but instead of doing this, you lay back the capsular rhexis along the direction in which came, and pull it in this direction and pull it inwards. And that's exactly what I do here. I explained it because it may not be very obvious in the video. Now I go in with a micro rhexis forceps, and essentially hold it, and then this is a regular Utrata forceps. I hold it, and as you can see, I pull it back in the direction in which it came, and then also internally, and thus I gain control over the rhexis, and then the rest of the surgery is fairly routine. And you can exchange in these situations the Utrata forceps or the micro rhexis forceps, the capsular rhexis needle, depending on your comfort. And time spent on doing this, always time well spent. As you can see over here, there is a certain amount of tendency for the rhexis to run off, which you are trying to control. And just because you have a $500,000 machine, that does not essentially assure you of complete rhexis in every case. in intumescent cataract like this, because of the surge of the cortical matter which sometimes occurs, you can see I have a disrupted capsule in spite of the fact that I had used a LRCS platform. Then I had a couple of flaps on either side, and the patient had already received a multifocal intraocular lens in the other eye. So we go ahead and implant the lens of the choice in this patient. Obviously not a compromised outcome, but then it could be dealt with only this. I would skip this video, and thank you so much for your kind attention.
Thank you so much, sir. I have one just doubt. In the third case you showed, there was a thick fibrotic plaque under the capsule. So could the femto complete a cut through that plaque?
No, I mean, I had used a femto in that case. That's why you could see the border of the rhexis in the rest of the place. But the thick fibrotic patch, it doesn't do anything to it. So that's why I had to. But it gives you a nice template for the rhexis, and so you get an almost rounded rhexis. But that area you have to cut with the scissors only. Thank you.